Greetings, my name is Lindsay Ma, and I'm a rising intern in internal medicine. Today we'll be covering acute myocardial infarction, or MI for short. It's an important condition to diagnose quickly because time is muscle. In fact, guidelines beg for evaluation within 10 minutes and a complete assessment within 20 minutes. Since this is a big topic, we'll cover diagnostics today but save management for another video. The target audience for this talk is clerkship level medical students, so let's see what we can learn today. Although the heart's role in perfusing the body is important, we can't forget about perfusion of the heart itself. Coronary arteries are responsible for this important job, but coronary artery disease occurs in 1 in 20 adults and is the most common cause of myocardial ischemia. Given someone in the US has an MI every 40 seconds, this will be the focus of today's talk. Let's say you're pre-rounding on a patient. They are 65 years old and are complaining of some new symptoms that they woke up to, such as chest pain, dyspnea, and diaphoresis. Yikes, it started at rest, so your suspicion for a stable angina is pretty low. However, you are worried about some type of acute coronary syndrome. You get to the room and you check for ABCs. Their ABCs appear to be intact, so you move on to MOV, which are cardiac monitors, supplemental oxygen if needed, and IV access. The patient is already on 2 liters of oxygen thanks to nursing, and they're satting well at this point at 96%. They already have IV access, and cardiac monitors are on the way. Now you have time for an abbreviated exam and history. Remember, we want to have our evaluation completed well within 20 minutes. What are some questions you would want to ask? You might ask more about their chest pain, if there was any radiation of that pain to the arm, the back, the shoulder. You might also want to know if it changes with exertion, since this would help distinguish between stable angina and acute coronary syndrome. They already told us that they have some dyspnea and sweating. They also might mention feeling cold. Some quote-unquote atypical symptoms can occur in women, those who are pregnant, and folks with diabetes. Some of those would be GI symptoms and syncope. Lastly, you could ask about any prior history of MI or coronary artery disease, since these increase your pretest probability for having some type of acute coronary syndrome. Moving on to exam, I'll let you know that this patient's exam was nonspecific. You didn't hear any of the findings that might make you more worried, which are S4 and a new murmur. And the point here is that just because you don't hear these findings doesn't mean you can rule out MI. Lastly, before you step out of the room to call your senior, you want to place 2 tests, and these should happen within 20 minutes of the patient presenting with these symptoms. Those would be a high-sensitivity troponin, and you'll get them serially, and an EKG. These should be ordered stat, and the results should be analyzed as soon as possible to guide management. Now, what is the diagnostic criteria for acute MI, and how are we going to use these tests such as the high-sensitivity troponin and EKG? Well, let's start with EKG, since that typically comes back before the high sensitivity troponin. Let's look at this EKG here together. I'll just tell you that the rate appears normal, the rhythm appears regular, and the axis is normal since leads 1 and AVF are both positive. Do you see any EKG findings concerning for MI? The ones that stick out to me would be ST segment elevations in leads 2, 3, and AVF, which would constitute some type of inferior infarct, or MI. It also appears that there are some elevations in the other leads too. We'll mark them in yellow. 4, 5, and 6. 4 correspond to some septal involvement, And leads 5 and 6 correspond with some type of lateral involvement. Some of the other leads are not shown here just for brevity. So going up to our chart, we can then fill out some of these blanks. The important part here is that ST elevations are unique to STEMI. ST elevations can also happen for reasons that are not acute coronary syndrome. So this blue box should be any other diagnoses. An elevated troponin. This is the other important criteria that has to be met in order to constitute as an STEMI. So here would be our high sensitivity troponins, and anything greater than 0.01 constitutes as an elevated troponin. Similarly to ST segment elevations, troponins can be elevated due to reasons besides MI, which is why the criteria that must be met for MI equals troponins being elevated plus EKG changes suggestive of MI or physical exam findings or imaging changes that show ischemia.
We'll skip details about imaging changes since it goes beyond the scope of this talk.
So what should go in this middle box then for a patient who doesn't have ST elevations but is otherwise exactly the same as what we've talked about so far? Let's say their troponin is 80. Well, that would be an NSTEMI or non-ST segment elevation MI. So the only difference we really see between STEMI and NSTEMI are whether there is EKG changes of specifically ST segment elevations. This box should be filled with physical exam findings concerning for MI. So what would go in the orange box then for a patient who doesn't have elevated troponins but does have physical exam findings concerning for an MI? Well, that would be unstable angina, which is still considered part of the acute coronary syndrome grouping, but because there is no myocardial injury, we don't see elevated troponins and we don't call this a myocardial infarction. It could happen because patients have musculoskeletal pain that is reproducible with external pressure and having nothing to do with the intrathoracic cavity. So let's summarize. If a patient presents with symptoms concerning for MI, such as chest pain, dyspnea, or diaphoresis, then we'll want to get their initial evaluation and assessment complete within 20 minutes. That evaluation will include checking their ABCs, addressing them as needed, also making sure that they have monitor, O2 support, and IVs. And then you'll want to take a brief history. Ask about some of the symptoms that they might have but haven't mentioned, such as atypical ones like GI symptoms and syncope, and any prior history of MI. Their exam could be helpful if they demonstrate a new S4 or new murmur, but the exam is often nonspecific. And then the two most important tests are the high sensitivity troponin and EKG. Order these stat right away. Once you have these two tests, you can start to parse apart what might be going on and what degree of acute coronary syndrome they might have. So if physical exam findings are already pointing you in the direction of ACS, then they would have unstable angina at the very least, unless proven otherwise. And then once the troponins arrive, if the troponin is elevated, you know that they have at least an NSTEMI, but that final EKG will tell you if there is ST segment elevations that would escalate their diagnosis to a STEMI, where NSTEMI and STEMI are both acute myocardial infarctions. Your time is precious, so thanks so much for joining me for this talk. Until next time.